Namaste everyone. Today we are going to talk about pregnancy and sickle cell disease, management from preconception to postpartum care. So certain common questions, confusions and uncertainty about pregnancy and sickle cell disease, like what is sickle cell disease? What happens in sickle cell disease? Some questions like, is pregnancy with sickle cell different from any other normal pregnancy? How do I manage pregnancy with sickle cell? What pain medications are safe to give in joint pain in pregnancy? Should I transfuse all patients with sickle cell? Can I treat patient with sickle cell or should I refer them to hematologist, etc., etc. So in today's video training, we are going to answer all of these questions. So stay tuned. All right, so what is sickle cell disease? Sickle cell disease is an inherited and an autosomal recessive disorder. Kindly note that it is an autosomal recessive disorder and particularly seen in certain castes like tribal population in pockets of India. It's a monogenetic disorder due to single base pair point mutation in beta globin gene, resulting in substitution of amino acid valine for glutamic acid in beta globin gene. So we are talking about hemoglobin. The globin part of the hemoglobin is what we are talking about, and the mutation is in that globin gene. So if we remember that red blood cells are usually round and flexible, they kind of are flexible enough to pass through small vessels, small capillaries. In sickle cell anemia, what happens is that these red blood cells turn into a sickle-shaped cells or C-shaped cells, which are more fragile. They sustain less in the life, and they end up clogging the blood vessels rather than flowing through the blood vessels. So what is the pathophysiology of this sickled cells? Is something you can think of something like a traffic jam. So what happens is this sickled cells or the C-shaped cells, which they block the small vessels. They get stuck in the small blood vessels, blocking the blood flow, like a traffic jam. You can think of it as a traffic jam. And in turn, it causes ischemia or oxygen starvation to the tissues beyond. This oxygen starvation or ischemia causes severe pain and tissue death. Another thing that happens in sickle cell disease is there is a constant chronic hemolysis that's going on. Sickle cells die early. They last for 10 to 20 days versus 120 days for a normal red blood cells. This causes chronic anemia, fatigue, and a component of jaundice. All right, so moving on to how this disorder is passed on generation after generation. So if we look at father who has sickle gene, like 50% has 50% sickle gene and 50% normal hemoglobin, and similarly mother has 50% of the disease. So both of them are carriers, and like when they bear children, what happens is like some of their children will have both sickle genes causing a homozygous disease, or what we call as sickle cell disease or SS disease. Some of their children will have 50% like their parents, and they are carriers, so they are like sickle cell trait is what is called, and like 25% of their children would have both healthy gene, so AA, and those children would have no sickle gene, hence do not have trait or disease. And this is like a autosomal recessive inheritance. All right, moving on to how we diagnose sickle cell disease. So typically in India, we use a screening test using a test tube and a chemical called DTT. A drop of a 20 microliter or a drop of blood is kind of put in the solution, and if it turns turbid, it is sickle positive. Now, this is a screening test. All it says that whether it is sickle positive or negative. If sickle is positive, we'll have to move on to a confirmatory test done by either HPLC or electrophoresis or DNA testing. Typically in India, we do screening test by DTT and then confirmatory test by HPLC, which will give us whether patient has sickle cell disease or patient has sickle cell trait. These days, we also have a point of care device like Hemotype SC and Sickle Scan, and there are quite a few other devices which are approved by Government of India, which are available and can be used in field setting, and it can directly give you the answer whether patient is negative, has sickle cell trait or sickle cell disease. Here is an example of a point of care test called Hemotype SC. It looks very much like a urine pregnancy test, and the readings would show whether patient has trait disease or negative. All right, so now let's move on to pregnancy and sickle cell disease. All right, so let's talk about the references from which we have collated the guidelines that the SOPs that follow in the slides that come along. There are certain national and certain international guidelines that we have reviewed. Also, opinions of local Seva rural experts based on their wide experience is also incorporated. All right, so screening for sickle cell anemia, the Government of India advises compulsory screening of all pregnant patients in sickle affected geographies. So what's the problem with sickle cell disease? What are the complications that we see in this disease? There are certain acute complications and there are certain chronic complications. In acute complications, the most common that we are seeing is vaso-occlusive crisis. Patient typically presents with multiple joint pains in vaso-occlusive crisis. The next is acute splenic sequestration, acute chest syndrome, a severe anemia, a hemolytic crisis, stroke, and a few others. In chronic complications, we have chronic anemia, renal failure, leg ulcers, retinopathy, and avascular necrosis of hip. Typically, no life expectancy related data is available for India. It's possibly somewhere around a ballpark figure of 30 to 40 years. Would request the trainees to go through complications of sickle cell disease in detail if they are keen. Now, besides the complication of sickle cell disease, there are certain maternal and fetal risks associated with pregnancy and sickle cell disease. So this is considered a pretty high risk pregnancy as the complications of sickle cell like vaso-occlusive crisis, acute chest syndrome, and anemia is increased. It also increases preterm delivery rate. Rates of PIH, pregnancy-induced hypertension, and eclampsia are increased. If we talk about the fetus, the growth restriction is seen more frequently. Similarly, perinatal mortality is also high, and maternal mortality is also very high in patients with sickle cell disease. So here are some data on pregnancy and sickle cell disease from 2016 to 2021, and the middle column shows data from 2011 to 2015. As you see, the maternal death is 30 times compared to their normal counterpart. Similarly, rates of blood transfusion, preterm delivery is almost 5 times higher than their negative counterpart. C-section is higher, low birth weight is a lot more common. Similarly, stillbirth and eclampsia is a lot more common. We have not noticed increase in rates of PIH, pregnancy-induced hypertension, in our population. So we have a couple of publications in terms of pregnancy and sickle cell. This is with data from 2011 to 2015. And here is data from 2016 to 2020-21. So when we talk about risk of maternal death, World Health Organization highlights that women with sickle cell disease are 4 to 11 times more likely to die during pregnancy or childbirth compared to those without disease. This is a paper from France. It says that maternal death is very lot more common in patients with sickle cell disease compared to their general negative counterparts. This is a paper from United States. It says the maternal mortality rate for people with sickle cell disease was 26 times greater than their control deliveries. So let's just move on to what happens, what we do at Seva Rural for sickle cell disease care. So Seva Rural is a voluntary service organization working in the field of health and education for last 45 years. It works on ideas and ideals of Swami Vivekananda and Gandhiji. It is based in rural, tribal, and poor district of Jhagadia in South Gujarat. So in Seva Rural, we have a very comprehensive sickle cell disease care management, starting from prenatal fetal screening to targeted newborn screening. We also manage pregnancy screening and its treatment. And we also do pediatric and adult management in outpatient and inpatient areas. We have developed a specialized IT system, and more than 3,000 sickle cell disease patients have been registered so far. So standards of care developed in Seva Rural is evidence-based. We have also taken up responsibility of generating evidence and continued improvements. And as discussed earlier, the SOPs are developed based on national and international guidelines, plus opinions of local Seva Rural experts based on their wide experience. So just to give you an idea of what we have done in a year at Seva Rural in terms of sickle cell disease care, we have seen close to 7,000 outpatients. Sickle cell related admissions were around 700. Total newborn screen were also around 700. Newborn disease babies diagnosed were 27. Pregnant patients screened 7,600, and pregnant patients diagnosed with sickle cell disease were around 48. So this is the volume that we are catering each year. Seva Rural has also been part of national committees on counseling in sickle cell disease and awareness modules on sickle cell disease. There are quite a few ongoing research happening at this point in time in Seva Rural. We also have a PhD candidate who is doing his PhD on sickle cell management at Seva Rural. So let's talk about preconception counseling in patients with sickle cell disease. What do you talk to them before they start thinking about conceiving a baby? So first and foremost thing is to establish rapport with patient and family, to provide them support, discuss high risk nature of sickle cell disease and pregnancy. We should also review current symptoms, any complications that are present, and if there is any end organ damage. Review and stop medications like hydroxyurea, ASI, or ARBs if patient is on any. We give folic acid, vitamin D, and vitamin B12. The couple should understand possibility of their baby inheriting sickle cell anemia. Remember, we spoke about the autosomal recessive nature of the disorder. So the partner or the husband should be screened for sickle cell anemia, and discussion about pre-implantation genetic diagnosis, invasive prenatal testing like chorionic villus sampling or amniocentesis should be discussed. Pregnancy should be avoided if patient has following conditions, things like severe pulmonary hypertension, cardiomyopathy, or severe alloimmunization. These conditions would put patient on to severe risk involved during the pregnancy. So let's move on to how to treat a patient with sickle cell disease on an outpatient basis. So first and foremost, we should offer prenatal genetic testing if it's applicable and available at your center. And this is the only way to identify whether the fetus is affected by sickle cell anemia, and whether the baby, the fetus, has trait or disease. It can be typically prenatal genetic testing can be done in three different ways. Chorionic villus sampling, it is done between 10 to 13 weeks of gestation, and technically it is a little challenging to perform. Number two, amniocentesis can be done. It is done between 16 and 20 weeks of gestation. It's easier to perform than chorionic villus sampling. And a third way to do it is by non-invasive prenatal testing. But NIPT for sickle cell disease is not easily available in India, and the cost might also be prohibitive. We spoke about this earlier. If mother and father, both of them have a sickle cell gene, either trait or disease, that couple should be counseled for prenatal genetic testing to see whether the baby has a trait or disease, or the kid is negative. This is the way amniocentesis is performed. Typically, it is performed under ultrasound guidance, and it is a relatively safe procedure. Though there are some procedure-related pregnancy loss, but in general, it's a relatively safe procedure. We also published a paper, a mixed method research on perceptions of patient and stakeholders on such screening. How do people take it and understand how amniocentesis is performed, whether they want to go ahead and do it, whether they'll be willing for medical termination, etc., etc. Treating sickle cell disease on outpatient basis, first and foremost, history and physical examination is something that is very basic to it. Evaluate patient's symptoms, any hospitalization or blood transfusion data, any sickle cell related complications that patient had. Ask for any joint pain, fever, shortness of breath, abdominal pain, or fatigue at rest or fatigue on exertion. Check vitals. Focus upon pallor, splenomegaly. So spleen is something that's understanding splenomegaly is crucial to the physical examination of patients with sickle cell disease. Look for any abdominal pain or joint tenderness. Moving forward, this is establish baseline. So this is, guys, this really focus onto this aspect of the outpatient management. Establish baseline of symptoms, vitals, spleen, whether it's enlarged or not, and how much is it enlarged, the baseline hemoglobin, reticulocyte count if it's available, reticulocyte HE, creatinine, SGPT, so liver functions, renal function, a direct and indirect Coombs test if it's available, and urine test for protein, and a retina examination. And you can also schedule patient for echocardiography if you think maybe the patient needs it. In terms of ultrasound, all patients should get a baseline ultrasound at the first visit, and then repeat ultrasound at 20 to 22 weeks for an anomaly scan. Growth scan should be done on monthly basis starting 28 weeks, as the baby is a lot more likely to be growth restricted. And start surveillance from 32 weeks, fetal surveillance from 32 weeks if there is growth restriction. Counseling forms a very basis of basis of how you manage patients with sickle cell disease. There should be a separate sickle cell counselor if it's possible for you to have somebody like that. Otherwise, the doctor or the nurse will have to take up this role. Ask patient to drink 10 glasses of water minimum. Avoid extreme heat, cold, or dehydration. And advise patient to come to OPD immediately if they develop any fever, shortness of breath, fatigue, or abdominal pain, or any other unusual symptoms. And refer all patients of sickle cell to OPD counselor after the visit if you have a dedicated one. So what you give in medication is you give folic acid 5 milligram daily. You also give aspirin 150 milligram daily till 36 weeks. We usually give paracetamol 10 tablets for minor pain episodes and give iron once a day after reviewing a patient's history of blood transfusion and lab parameters. So key messages for outpatient OPD management is confirm diagnosis, give folic acid, aspirin, supplement iron, and establish baseline hemoglobin and other parameters. And offer prenatal testing if husband is sickle cell trait or disease. Moving on to treating patients with sickle cell disease on in indoor basis, indoor situation. So now let's talk about when to admit the patient. If patient has persistent joint pain even after oral medication, a hemoglobin drop of more than 2 grams from baseline, increase in spleen size more than the baseline, or if there is pain in left upper quadrant. If there is any hypoxia, SpO2 drop less than 95%, if there is high-grade fever, and of course, you also admit patient for obstetric indications like labor pain, etc. So the referral criteria, of course, it will vary based on where you are located, based on the expertise and the facilities available. But generally, for a secondary level care, patients with hypoxia or for possible need of a ventilator should be referred. Patients having blood transfusion incompatibility, patients with unexplained tachycardia, sick-looking patient, a patient with persistent joint pain even after multiple analgesics. And lastly, if you don't have experience or expertise in management of pregnancy with sickle cell, patient should also be referred out. So treating it's important to keep a dedicated bed or an area where you would admit sickle cell disease patients. Keep a senior medical officer or gynecologist in loop so that he or she knows the patient, especially when severe complication arises. Now, educate patient and relatives about seriousness of the condition and take this as an opportunity to screen family who's come along with the patient. Monitor basic vitals, temperature, pulse, respiratory rate, blood pressure, and SpO2. The charting should be done at least 4 times a day. Input-output charting should be done. A daily CBC, especially in acute cases, and investigations like complete blood count, liver function, renal function, electrolytes, blood group, and peripheral smear for malarial parasite if patient came with fever. Also should check out for dengue if patient has fever plus thrombocytopenia. Okay, coming to pain management, the thing that we are looking for is to make patient pain free. You can combine multiple drugs if persistent pain is there with one analgesic. The drug of choice for as an analgesic in pregnancy is paracetamol, 1 gram every 8 hourly. If paracetamol pint is not available in your setup, you can also become creative and use 2 or 3 ampoules of febrinil in NS, 100 ml NS. Analgesic number 2 is you can use tramadol, 1 ampule every 6 hourly along with MSED, or your ketorolac or any kind of NSAID is also a good drug for persistent pain. Avoid using NSAID after 32 weeks, but we may use it in severe pain cases. If patient has pain even on tramadol and ketorolac, add morphine, FMP-SOS. And you can also consider pentazocine, ketamine if persistent pain. Okay, coming to hydration, typically what we were taught in medical school is like any patients with sickle cell disease, just hydrate them. Just tank them up, so that the viscosity will decrease and sickling will decrease. All right. So guys, focus your attention here. Provide intravascular fluid only if patient is not able to take enough water orally. Do not tank them up. Okay. In case of dehydration, administer intravenous fluid. However, definitely avoid overhydration. Overhydration is going to cause a lot more damage than underhydration, especially in patients who is able to take orally. Okay. Advise patients to take at least 2 bottles of water, each bottle measuring liters. Use lactated ringers or normal saline in case intravenous fluids are needed. Oxygen is given via nasal prongs or mask if patient is hypoxic, along with tachycardia, or if patient is anxious looking. In terms of antibiotics, we give injection cefoperazone sulbactam IV BD for patients who have raised white count of more than 12,000. Just keep in mind that automated cell counters would read nucleated RBCs as white blood cells, and hence always get corrected white blood cell count if white blood cell count from automated cell counter is high. Also get a reticulocyte count if available in your setup. It provides a good insight into whether patient is going for sequestration crisis. Treat malaria if smear is positive. Next coming along is thromboembolism prophylaxis. All patients who are not able to move around should be given LMWH, low molecular weight heparin 0.4 subcutaneous once a day to prevent thromboembolism. All right, so sickle cell disease anemia is a very important aspect of the whole diagnosis, treatment, and management. It's important to maintain adequate hemoglobin. Investigate to find out what is the cause of anemia. Do reticulocyte count, vitamin B12, ferritin, check for splenic sequestration, whether the spleen is increased, whether the liver is increased. Identify the cause of anemia, or at least try to identify the cause of anemia rather than just giving blood transfusion. So when to transfuse? Drop in hemoglobin of more than 2 grams per deciliter compared to the steady state hemoglobin that we identified at the baseline at the first visit. So give transfusion only if there is drop in 2 grams of hemoglobin in an asymptomatic patient. Number 2, transfuse before delivery to reach a steady state hemoglobin. And you definitely would have to transfuse if patient has complications like acute chest syndrome or splenic sequestration or any other complication. But kindly avoid unnecessary transfusion. Sickle cell disease does not directly mean to transfuse patient. There is a risk to blood transfusion, like blood transfusion reaction, alloimmunization, etc. So kindly avoid unnecessary transfusion. Now moving on to exchange transfusion. Exchange transfusion is indicated with persistent joint pain even with multiple analgesics, if there is acute stroke, severe acute chest syndrome, acute multi-organ failure, or episodes of hepatic or splenic sequestration. So key messages for indoor management is avoid overhydration with IV fluids, avoid unnecessary blood transfusion, close monitoring of vitals to detect early detection of complications, incentive spirometry, and prophylactic anticoagulation in vaso-occlusive crisis. All right, so how do we deliver patient? How do we manage patients at delivery? The delivery should be planned at the center with experience and expertise to manage patients with sickle cell disease. Induce the labor or go ahead with elective C-section for obstetric indications at 38 weeks. We don't induce or deliver patient while patient is in acute crisis or has acute complication. Monitor labor and labor with fetal monitoring device as baby is at higher risk for distress due to fetal growth restriction. We go ahead with vaginal delivery as far as possible and reserve cesarean section only for obstetric indication. Give oxygen if SpO2 is not maintained, and epidural analgesia if it is possible in your setup. In terms of postpartum management, keep patient in close observation, either in ICU or in HDU or in a place where you can closely monitor the patient. We do hourly monitoring for at least for first 6 hours, input-output charting, and pain management. Now that patient has already delivered, you can go ahead and use injection ketorolac or any kind of NSAID for pain, tablet PCM or injection PCM, and morphine for severe pain. Again, hydration after normal delivery, when patient is able to take orally, no need to give IV fluids. Patient is advised to take oral fluids and liquids. Patients who have had C-section. Patients who have had C-section also get no more than 500 to 1000 milliliters perioperatively, and a maximum of 1000 ml in 24 hours. Patient is encouraged to start taking oral fluids in 2 hours for an uncomplicated cesarean section as per IRA's guidelines. Offer contraception to patients while patient is in the hospital with you. Offer levonorgestrel, IUD, or DMPA to all patients. Encourage them for permanent sterilization if they have completed their family planning, and encourage breastfeeding. All right, let's talk about management of newborns born to mothers with sickle cell disease. Sickle cell disease mothers are more prone to preterm birth, babies with low birth weight, and babies are also at risk of perinatal mortality. Mandatory screening for neonatal hypoglycemia and hypothermia. Maintain a strict maintenance of warm chain and kangaroo mother care, especially for low birth weight babies. Early screening for sick babies' status of sickle cell disease, straight or normal, should be done even before discharge. All right, thank you very much. Together, let's take forward the care of patients with sickle cell disease. Thank you.